So to kick off our Q&A session, does anybody in the audience have any burning questions for any of our panelists seated here? If you do, just raise your hands and we'll pass you a mic. Okay, while we're getting our audience warmed up, maybe you guys, take a few minutes to think about your questions. I actually have a few questions online already, so maybe I'll just go through them. The first, maybe quickly, I'll ask Dr. Ooi. There's someone asking, how do we get enrolled into the Golden Program?
Thank you, Melinda. So you can actually ask, the Golden Program is actually an NUH program. So they may have similar things in SGH or Tan Tock Seng, but called something different. Essentially, it's a geriatric referral. So in NUH, you can just ask your doctor to contact any of we have specific people doing it in various specialties. So you can just ask your doctor to refer over to us.
Okay. So, we have a question.
Yeah, I'd like to hear from either Dr. Chandra or Dr. Darutan regarding new myeloma drugs that are not approved by HSA. We saw quite a number of new drugs approved by FDA, a lot by FDA. But what about, are they also approved by HSA in Singapore? And are they allowed for insurance purposes?
Maybe I go first. So some of the medicines that come for approval have to go through their pipeline. So initially, most of the drugs get approved by FDA first because most of the trials have been performed outside of Singapore, usually typically in US. So they get FDA approval first. And then they go through different other countries' approvals, including Singapore HSA approval. So the last of the drug that I put on my slide called Selinex or Expovio, as I mentioned, has been approved by HSA already just in the beginning of July, actually. So that is available and approved at the present time. The other medicines, including the CAR T-cell therapy, as well as some other BCMA-directed therapy, like the belamaf that I mentioned, they're all going through the approval process in HSA. So I would think that over the next 6 to 12 months, you will find that some of these medicines will be approved by HSA. Now, as we have learned, over the different presentations we've had this morning, approval doesn't automatically guarantee access. Approval is a license to access, but lots of other factors come into play after the approval. Cost is a big one, but also, just because a therapy is approved, it may not be the right one for an individual patient. So there is other factors that is beyond the approval that we need to consider when it comes to patient access for individual patients.
So just to add to what Muli has explained, usually HSA approval comes typically maybe like 6 months or 1 year after FDA's approval. Of course, FDA and EMA, the European Association, will usually be the first to approve certain drugs. But in Singapore, even before HSA approval, there is a safety net called the Named Patient Program, where if we think that our patient has exhausted all means, all drugs, then we can write in specifically for HSA to grant an exception to allow this drug to be brought in and to be given to a particular named patient. So this is a safety net for some patients. By and large, if you're asking about insurance coverage or subsidized drugs, it takes longer before subsidy comes in. But for a patient who has an insurance, usually if the drug is already approved by FDA or EMA, we usually try to make a case for this drug to be approved by the insurance. Usually, by and large, if it's a comprehensive insurance, it should be approved. So right now, some of these drugs that are making to the cancer drug list, which you can Google and you'll see what drugs are approved in the cancer drug list. It goes hand in hand to a certain extent with HSA's approval, but the subsidy is variable. So there's a lot of variable depending on your insurance program. But if a drug is required, I'm sure your doctor will want to try to procure the drug for you by tapping to various resources.
Thank you. So maybe with that question, I'll move on to one of the questions online, which is pertaining to accessibility of drugs. Some participants are asking with regards to how many of these drugs are accessible to patients on subsidized cases. They are subsidized patients and not private patients, and how many, what kind of drugs are available to them. I think this is pertaining to the changes come September 2022. And I think they may have some worries about, what kind of drugs they can afford subsequently. So maybe if I can get Dr. Melissa Uif to talk about the subsidized, sector, and then Dr. Darrell Tan to address, patients in the private sector, and then after that I'll get Grace to perhaps talk to us about what the social worker's role is then.
Okay, thank you, Melinda. So I think there is a lot of uncertainty and fear come September. So right now we are actively reviewing the patients who are on certain drugs that may have not made the cut to see whether in conjunction with the patient, it is something we want to do to talk about switching therapy or what the options are for the individual patient. So if you feel that you are one of those patients that may be affected, as I said, the CDL or the cancer drug list is available on MOH website. You can just Google cancer drug list, and the whole list of drugs will be there. Might want to do it on a laptop because there's a lot of words if you're trying to do it on your phone. And then you can see if the drug that you're on is on the list, and there are specific, they do have a little column that says how much subsidy, etc. And if you feel that you're one of those affected, please do reach out and talk to your doctor, because we are all aware and we are working actively with pharmacy, with social worker, to see how we can support patients who are the most affected by the changes come September. The reason I mentioned September is because that is that's when the subsidized patients will be affected. The private patients will only get affected by next year, April. For MOH has said that for patients in transition, the in-flight patients who may be still benefiting from treatment but whose drugs aren't on the list, there are safeguards in place. We have other ways and means of applying for medication funds for these patients, and MOH has assured us that they would help, especially those patients that are in flight. Because if they're still continuing to see benefit, as physicians, we can individually apply for additional funding for these people through things like MAF Plus, etc. So again, do talk to your doctor if you feel that you're affected by these changes come September.
So most of my patients in private, they usually have a rider. So in myeloma, it's just impossible to be a self-paying patient because drugs are so expensive. So with rider come September, there shouldn't be much impact for patients with an IP program, IP plan, SHIELD plan plus a rider. Now, what we do not know is that come April next year, whether those with rider will have to abide by the cancer drug list. The insurers themselves are formulating, they will only let us know in this, probably end of the year in December, if these patients with rider will come April next year, their prescription has to conform to the cancer drug list. I will only be able to tell you when the insurers come out with their new policies. In the cancer drug list, most of the drugs that are needed for myeloma are already there, but the newer drugs, hopefully the HSA and ACE will approve these drugs to be allowed to be put on the cancer drug list, so that's easier for doctors to prescribe these drugs and for insurance companies to approve these drugs. But just rest assured that we're always doing our best to write into these agencies to expedite the process, because as a patient, sometimes you cannot wait for months just for drug approval, so that you can get the drug when you most need it. Molly, you've got anything else to add?
No, I think it's a joint effort. We always work with MOH. ACE is the body which kind of decides on medicines, what is effective, what can be used, and of course they'll have to come also from the pharmacoeconomic perspective as to what would be the best buck for the best efficacy in terms of the amount of money that they have to pay from a public healthcare perspective. But at the end of the day, I think, as we were mentioning yesterday, as a group of patients, when we get the feedback and they have, opportunities for you to participate in the discussion as well. So those patient voices are absolutely crucial if we have to make a move in terms of, especially in the future, when we get more medicines, newer medicines, as some of them I was mentioning earlier, to get them the subsidy so that a lot more patients can benefit. I think it's important to have the patient voice.
Yeah. So with regards to accessibility for these treatments, so at government hospitals, the social worker will review whether these patients qualify for subsidies. We also work very closely with the oncologists to ensure that, the treatment, if it's really worth a try, they are also on some form of subsidies if they are financially needy. We also reach out to Singapore Cancer Society. So they have this cancer treatment fund for HSA approved drugs. It's up to $50,000 per lifetime. Per month is about 6,000 that they can actually assist, but of course up to their medical board review and financial review as well. So we do reach out to these organizations as well as our own subsidies to see how we can better support the patients through the treatment. Yes.
Thank you. So with that, maybe I'll ask the next question. I think there are some questions on how do doctors decide which treatment protocol do we choose for treatment. So that's probably a whole lecture by itself, but maybe, general broad principles. And in particular, there is a patient asking, a lot of us use VRD in the frontline treatment, but they've also come across other variations. For example, VTD PACE was what he's stated specifically, and which group of patients receive this. So maybe Dr. Muli, would you like to address this question?
Yeah, thank you. Indeed, we can discuss probably for a whole day, but in the interest of brevity, I would just say there are several factors that we consider. One, probably the most important, is the patient and what they bring with them in terms of their organ functions. How are the kidneys? How is their heart? Whether they've had a prior heart attack, for example, or do they have diabetes, high blood pressure, etc. Second is where they are in terms of their treatment and how has myeloma affected them. So, for example, if a patient has significant kidney failure, even at the time of diagnosis of myeloma, what we might offer as treatment might be a bit different to somebody who at the same time of diagnosis does not have kidney failure. And third would be, if they are relapsed patients and they've perhaps had 1 or 2 prior lines of therapy, what are the medicines they've had in the previous lines of treatment, and what side effects or toxicities from these medicines that they have suffered in the past, but also whether they have any side effects that are still persistent at the time of them needing a subsequent treatment line. Generally, as doctors, we don't prefer to discuss a lot about the economic side of things, but it's a very big thing on the patient's mind. So increasingly, we are having to, take that into the equation because, over the last 5-10 years, we have realized that's especially in Singapore, we cannot get away from it because a lot of patients have to, in some way, shape or form, even after subsidy, it's a big consideration. So that is an important thing that we also have to take in mind. So we try and work within the framework of the cost of the patient's comorbidities, their past medical history, what drugs they've had, etc., and then come out with the regime. One advantage, if we can call it that way, is in myeloma that we have different groups of drugs. And I was just trying to work out based on the international guidelines that we have for myeloma treatment. With individual, group of medicines, we are almost able to come up with nearly 40 different regimens that patients can potentially have. So there is an opportunity that, plenty of combinations that we can use. So within the 40, we'll have to try and choose what is the most appropriate regimen for the patient.
Thank you. That was very succinctly put. Next up, we'll ask Lynn a few questions. So a participant has a concern about red meat, specifically because red meat contains sialic acid. So they're asking if they should eat less red meat to reduce cell inflammation and to increase immunity. Is that something that you would advise?
Thank you for the question. So for red meat, actually, there's quite strong evidence to promote colorectal cancer, but not much in myeloma patients. So usually, a lot of my patients actually have low hemoglobin, which is red blood cells actually. So red meat is actually quite a good source of iron. I usually don't encourage my patient to avoid them. I will instead, based on the World Cancer Research Fund, actually they promote red meat intake as long as it's less than 500 grams per week. So I think that's still quite safe to consume. Yeah.
Thank you. What about your advice about yogurt? So in a patient who is, say, 30 days post-transplant and he says that his blood counts are normal, what would you advise patients usually in this scenario?
So good question. So usually, at least in NUH, we agree with the doctors that usually products with probiotics actually we to avoid until probably after the 3 months post-transplant, when we can discontinue the neutropenic diet. So that's when we can perhaps introduce it back into our diet whenever, provided that all the platelets and neutrophils, white blood cells are back to normal. Yeah.
Thank you. Thank you, Lynn. So next, I'll move on to a question about assessing treatment response. This is to Dr. Darrow. So they're asking, how and when do you assess treatment response, and when do you actually assess for MRD negativity? Is it when, a patient is in remission, would you then do MRD assessment?
Okay, so good question. I don't think there is a uniform answer if you ask all the myeloma doctors here. But generally, once we start treatment, we want to see if the regimen is effective. So after one cycle, we will do a blood test just to see whether the M band is coming down. And typically, I've mentioned check the M band, immunofixation, and light chains is usually thrown in as well, especially for patients with a type of myeloma called light chain myeloma, where your M band is not a suitable gauge to assess disease response. Typically, whenever I do a blood test, I would check these parameters to look at the trend and to see if the patient is responding. Now, when do I do MRD assessment? By and large, it is not like it's not prime time for us to routinely order MRD. The reason is because the test is a little more expensive, and also we do not know what will be an MRD level to change treatment, because these trials are now ongoing to tell us in future what we're going to do with MRD results. But for some patients who want to know if they're MRD negative, usually I time it when I'm doing a bone marrow biopsy. When do we do bone marrow biopsies? Usually, some physicians do it right before transplant to see that the patient is responding. If the patient is responding, they go ahead with transplant. Some physicians will skip that and do the bone marrow biopsy after the transplant. Yes, after the transplant, typically is when I want to assess if a patient is responding. I will count the plasma cells in the bone marrow if they have come down, and if I'm doing a bone marrow puncture, perhaps, yeah, why not just assess the MRD during this time? So I don't, because no patient wants to do bone marrow biopsy on a regular basis. After transplant is a good time for us to assess. And also some patients who are on maintenance or who have been on treatment for a long time and they say, hey, doctor, I'm tired, I want to come off treatment. Well, right now in myeloma, from the latest data, even on maintenance, it seems like it's better if you continue maintenance indefinitely than to have a fixed duration maintenance after a transplant. But some patients who just want to come off treatment, sometimes I could just do a bone marrow assessment to see if they're MRD negative, and if they really want to come off treatment, I could go by that. But this is just my personal practice. So by and large, I just want to clarify that MRD assessment is not routine, but occasionally we could do that for prognostication. And one very important thing is for high-risk patients, I always want to ascertain if they are MRD negative after the transplant, because if they are not, I would probably want to consider more treatments or even a second transplant for patients with high-risk disease.
Thank you. That brings us into our next question about transplant. So if a patient can't get through, transplant because their bone marrow can't produce enough stem cells, or if they are elderly, and they're not fit to undergo a transplant, then what would be the alternative treatment or, treatment regime, treatment strategy in this particular group of patients? Maybe I can ask Dr. Ooi to address this.
So I think that I'd just like to clarify about the not being able to produce enough cells for transplant.
Yeah, I think they mean that they probably could not mobilize enough stem cells, and therefore they were not eligible for stem cells. So perhaps in that group of patients as well as ineligible patients.
So I think upfront, usually the decision will be made. Unfortunately, we do use age as a sort of general cutoff. It's not set in stone. But if the patient has a lot of comorbidities, medical problems, organ function not good, we may already upfront say maybe they're not the fittest for transplant. We don't want to put them through because we feel that they may not tolerate the transplant very well. Because transplant, unlike the regular treatments that you might be getting for myeloma, is quite a bit harsher. It is old-fashioned chemo. You do lose your hair for this one, unlike the other myeloma treatments that we are undergoing. You do suffer from nausea, vomiting, diarrhea, and so those who have been for transplant usually will tell you that it's the roughest part of the myeloma journey. So upfront, if we already decided that they are not fit or they may not tolerate transplant well, then we would usually try to give them, as what Darren said or Maureen said, the best treatment upfront, so that they, like the first one is the best. You get the best response, you get the best remission. So right now, I think that it also depends on patient factors, financials, how we will approach these patients. I think that come September, there may be some changes, whether if insurance or not. Again, that would all come into the discussion as well. So there is no one fixed regimen that we would give. VRD is still a consideration, which is a standard treatment that we would give for actually most patients. But obviously, if let's say you have some insurance coverage, you want something better like daratumumab with lenalidomide, dexamethasone, that would also be something in consideration. That is allowed under the CDL. Then in terms of those who end up unfortunately not being able to mobilize, so you started off going for the transplant, but you didn't manage to collect enough cells, there is actually special medicine that you can use to try and actually mobilize the patient if you failed the one time. So it's not all no hope. You can try one more time. If you still cannot get the cells out after that, then don't despair. The treatment can still continue on with what treatment that you're currently using before your transplant was started. Or let's say if your MRD is not so good, or you're not responding so well, then the doctor may change your treatment accordingly. So it's very hard to give specific regimens, because I think that I don't want to pigeonhole anyone to sort of say you must go this down, because that would be a decision that you would have to make with your doctor, depending on your medical condition.
Thank you. Lynn, I have a few more questions for you about what people can and cannot eat.
Always welcome.
So I think patients are asking about Chinese herbal soups. What would be your advice on that?
Okay, so I'm not too sure if this patient means during treatment or after treatment, but usually after treatment we will probably allow, but do double check with your doctors. But during treatment, actually, because of a lot of chemotherapy medications, usually I will not allow. Yeah, I just worry about the interactions with your treatment drugs.
How about beetroot juice?
Oh. So like probably you've seen on my slides, juicing is one of the common things that patient ask me. So the risk is that when you juice things up, some patients who really want to insist on going on to it would have to be really careful with hand hygiene and peeling off the skins and things like that. But actually, because there's no solid evidence to how that would help you during your treatment, so usually I will not promote. And some patients are open to talk about it, but some who want to insist on going on it, I just need to reinforce to them about hand hygiene, peeling off the skins of anything that you want to blend in your own blender. Yeah.
Okay, I think this is quite a similar question to alkaline water. I'm not sure if you are familiar with terahertz water.
I've heard of it.
Okay, then it's okay. Maybe we will leave that for another day. The next question, maybe I'll ask Dr. Chandramouli. This is pertaining to maintenance therapy and in a patient who is active and in the workforce. So perhaps what are the considerations that firstly the patients can explore with their employers? What are the discussions that should have been had or should be had with both the employers and the doctors to come up with the best available treatment that is also suitable to maintain their own quality of life?
That's a very good question, actually. So fortunately for us, at least the most commonly used medicine for myeloma maintenance therapy is oral. So it will spare them a trip or two for them coming back and forth into the hospital. But it's probably also relevant that in the coming future, we're going to have perhaps more drugs, including drugs that are going to need to be given intravenously or even as an injection under the skin, which means that the patients would, on a longer term basis, still need to come and have the treatment in the hospital. But overall, I think the biggest, the issue that is mentioned in the question is how do we cope with the longer term side effects? Because by definition, maintenance treatment is for longer term, and there are patients who have stayed on maintenance 2, 3, 4, 5 years. The issue of fatigue and all those things, I think it's a constant thing, one that needs careful managing. And as we have shared some of the tips and tricks and how we could manage those things, probably something that we need to bear in mind. Sleep, eating, all those things go into that as well. And the other side of the question was about employer, how do we mention that? I think I don't think there is a, fixed clear answer that we can say, but perhaps always, when patients come and ask us about, how can we, it depends on your, what job you're doing. We are more than happy to provide letters to say, okay, maybe within the scope of your employment, is there a different place that they can place you at that probably, for example, there are lots of patients, for example, working as security guards in the middle, after evenings, night shifts, etc. And by asking them to not be put on night shifts may be of help to them. So things like that we are more than happy to help with in terms of adjusting their work lifestyle to adapting them to the myeloma maintenance therapy.
Thank you. Before I go on to more online questions, is there anyone in the audience that is burning to ask our experts here anything? You can raise your hands or just shout it out. No, all very shy. Okay. So I have one more. Basically, after reading Chris Beats Cancer, they are wondering if there is a future potential for holistic healthcare in Singapore or even post-transplant. Is there a lifestyle mentor to help, continue a healthy and active lifestyle? So I think maybe the question would therefore be, what are the avenues besides our myeloma patient support group? So this is one. What are the avenues where they can perhaps get support, both lifestyle-wise, exercising, or maybe even mental health-wise? That was Grace, if you want to address that.
At Tan Tock Seng Hospital, we have this cancer rehab clinic that Dr. Wong is running. So they actually help patients to regain back their function, back to their normal lifestyle. So there's physio on board and also occupational therapists. I understand that at Singapore Cancer Society, they also have a rehab center. So that's possibly another avenue also that patients can go there to just connect with one another and at the same time get back to their normal lifestyle as well.
I'm not sure if Dr. Uy has anything to add about that.
So unfortunately, in Singapore, I think this kind of support group is still quite, immature compared to in Europe and in the US. So we don't have a holistic, I think what you mentioned, the support group, guru to help out. We do have people who are interested, specifically in NUH. My nurse practitioner, Lim Chi Ching, who some of you may know, is actually very keen on survivorship in myeloma. And part of her nursing sort of masters is actually trying to look at this particular thing. So she normally sits in with Prof. Cheng on the Friday morning. Before COVID, she was sitting on both the Wednesday and the Friday morning clinics with us, and she would actually look at which patients are on our list who are like post-treatment, on maintenance, and specifically address survivorship issues such as bone health, even sexual health, lifestyle, physical, etc., emotional. And so because of COVID, she kind of had to choose one clinic over the other, and she chose Prof, unfortunately. She didn't come and join me and Sanjay, but hopefully now that COVID is, I don't know, probably here to stay, she might come back and join us on Wednesday. But if there's any specific issues, please do let us know, because as I said, she has a special interest in this, and she is very keen to explore this.
Thank you. So I'll take one last question because we're overrunning a little bit. And I think this is again pertaining to cost. So I think this patient or caregiver is asking about, let me find that. Sorry, I just lost that question. So pertaining to after September, so the drug list again, does the decision of the treatment combination depend upon the available drugs in the cancer drug list? This is probably quite a tricky question to answer.
No, it is, unfortunately. We have to prescribe within the cancer drug list, and if they specify a combination, then we have to follow that combination so that the patients can either get the subsidy or if they're MAF, if there's any MAF means medication assistance fund. So the certain drugs, depending on your means testing, can get additional subsidy for the cost of the drug itself. And also to be able to use your MediShield and your MediSave to help defray the cost of the drug. So if they have a combination listed there, which is I think the third column, we have to prescribe as it is written in the combination. If there's no combination, then there may be some leeway in how we prescribe.
Thank you. So any further last questions from our audience? No, if not, we'll conclude today's Q&A session. Thank you very much to all our panelists.